Hello. Thanks for taking the time to check out some of our work. My name's Chris. I'm from the University of Melbourne. I am Program Manager for the Victorian Comprehensive Cancer Centre's Data-Driven Research Hub here in Melbourne, Victoria. And as at the time of this recording, I'm doing a lot of staying indoors. But hopefully that changes pretty soon. And I also hope that things are going okay wherever you are in the world. So this piece of work, which has been in the making for the last 4 or 5 years, seeks to build an enduring, centrally accessible, ethically appropriate mechanism for researchers to access large-scale linked data in a timely manner with minimal costs. So this infographic shows some of, but not all of, the types of data that we have, and we'll be linking through the program with the foundational data coming from 2 main sources. One is mandated statewide reporting data from hospitals, which includes admitted, emergency, not admitted, elective surgery and radiotherapy data, which is ideal as it's standardised across all hospitals and therefore can be incorporated and scaled up with minimal effort. And the second is from primary care data sources, which include NPS Medicine Insight, which is a national collection of primary care data extracted from general practice software, for which we have access to the Victorian subset of patients, and a University of Melbourne developed primary care data resource called Patron, which is just now ready to be linked. Additionally and critically, we also work with custodians of clinical and population registries to include definitive diagnosis and outcomes data, in addition to much more granular treatment and progression information than we can access via administrative or funding data sources alone. Very briefly, the NPS Medicine Insight primary care data is summarised here. This represents just over 10% of all Victorians' attendances in general practice over the period of 2007 to 2017, and we'll soon be updating that to be closer to present day. There's an overview of the types of data available, with the highlights here being why patients are presenting, what they're being prescribed, what tests are being requested, results returned, and condition diagnoses. So next, here we have a quick example of what it starts to look like when we link between primary care and hospital data. In this case, this is the NPS Medicine Insight data linked to 2 large tertiary hospitals. That's the Royal Melbourne and Western Health. And where we have numbers in the overlapping sections of the Venn there, you can start to build a more complete picture of how patients are moving between primary and acute care. And you can also get a sense of scale and scope, with about 2 million patients in NPS primary care and more than 500,000 between the 2 large hospitals over the 10-year period. So what is it that we're hoping to achieve? Well, the potential for answering different questions grows each time we connect a new data source. But the key themes, certainly in the context of cancer, fall into one of 3 overlapping categories. The first is to look upstream of diagnosis to detect patterns of presentations which may be symptomatic or include routine investigations, require medication control of symptoms, or have other key features that may characterise a future cancer diagnosis, which would ideally allow us to support design of future systems and capability for those patterns to be systematically recognised and therefore diagnose and intervene earlier. Secondly, we can better understand how patients are engaging with different parts of the acute system and primary care during their treatment. And finally, we can look downstream to identify how all of these factors relate to outcomes, look at disparities between certain groups, managing comorbidities, improving quality of life, optimising follow-up care via mediums such as telehealth, which is becoming increasingly relevant in the current climate. By way of a brief example, we are collaborating with a team of bone and soft tissue cancer specialists from the Peter MacCallum Cancer Centre, and they've got a clinical database called Accord, which contains detailed diagnostic and treatment data, along with comprehensive history and follow-up information for around 2,500 patients. So we've linked this to the NPS Medicine Insight data, which allows us to supplement their data collection with the more detailed content from primary care. And in doing so, we've found out 310 patients that have a matching record between both data sources. For some context here, bone and soft tissue cancers are relatively rare, have high variation, and are therefore more difficult to diagnose accurately. There's also considerable evidence to suggest that timely access to a specialist centre is a main contributor to improved outcomes for these patients. The Peter Mac is one of 2 such specialist centres in Victoria. So with our patient cohort of 310 patients who are shared between Accord and the NPS Medicine Insight primary care data, we can see that these patients are visiting a GP an average of 5.8 and 8.1 times in the 6 and 12 months prior to diagnosis respectively, and keeping in mind here that coverage of the primary care data set is incomplete, so these numbers are likely to represent a minimum. With this information, we can start to look at how patients are initially presenting in primary care, where symptoms are present, which routine tests could potentially be indicative of a diagnosis, time taken to access a specialist centre or achieve an accurate diagnosis, and duration to treatment, which is particularly meaningful in the case of one of the 2 statewide centres here in Victoria for bone and soft tissue treatment. Then downstream, we can use the primary care data in a similar way to supplement follow-up data from the hospital and start to build a more complete picture of the patient's experiences and needs, with the aim of designing systems that improve their outcomes, manage comorbidities, ideally in a streamlined way, and also embed processes that allow for fast tracking back to specialist centres if there's a suspected recurrence or complication. So in order to achieve all this, we work very closely with Biogrid Australia, who are a not-for-profit organisation with well-established infrastructure, technology and expertise in the governance, linkage, management and access to health data. They operate using a federated system, which allows for data to be securely transferred out of an origin organisation into Biogrid, where patient identified data are converted into unique IDs, then removed. And that process is replicated across as many linked data sources as have been requested by the researcher, which allows for those data to be de-identified and shared such that they are linkable by the researcher. Critically, custodians retain complete control over their data and must provide explicit approval for it to be accessed for any purpose. This makes up one of the 3 key data release checkpoints at Biogrid, which includes the custodian approval, acceptance of terms of use of data by those requesting access, and approval by a Human Research Ethics Committee before data will be provided in a secure manner. In the case of our project specifically, Biogrid provides these critical functions along with governance advisory, ethics and project support, analytical skills, and they act as an intermediary between us and their 40+ member organisations and collaborators. So big thanks to Maureen Turner, who's the CEO at Biogrid, for providing this particular content for me to use in the presentation, and to her and the whole team, without whom our work just wouldn't be possible. So I'll wind up here, but please do feel free to reach out if you'd like any more detail, or if you'd like to share your own work or ideas. We'd love to collaborate and learn from others too. So thank you very much for your time.